In this lecture, the osseous, articular, and muscular structures of the knee complex will be discussed. The femur, or thigh bone, is very strong and is the longest bone in the body. The head of the femur is a projection at the proximal end of the thigh bone and is supported by the neck of the femur. The head is smooth and globular, its surface being covered with cartilage to articulate with the acetabulum of the pelvis to form the hip joint. The neck of the femur connects the head of the femur to its shaft. Most of the blood supply to the head runs along the surface of the neck, and therefore injury here can lead to a vascular necrosis of the head. The shaft of the femur is a tubular body that is slightly twisted and curved. Along the length of the shaft of the femur, posteriorly, is a landmark feature called the linea aspera. Between the epicondylar projections at the distal end of the femur, onto which the collateral ligaments of the knee attach, is the patella, or kneecap. The patellar surface is a shallow area on the distal end of the femur. It lies anteriorly between the anterior-superior portions of the femur condyles, which accommodate the patella. The tibia, or shin bone, is the largest of the two bones in the lower leg. It is subcutaneous throughout its length and can be easily palpated. The proximal and distal ends of the tibia are known as the superior and inferior articular surfaces. The superior articular surface of the tibia is a smooth surface on each of the condyles. Here, the lateral and medial condyles articulate with the condyles of the femur. The superior articular surface is separated by the intercondylar areas that serve as points of attachment for the cruciate ligaments. Also located here is the patellar tuberosity. The tibial tuberosity is a rough area on the bone and is the attachment site for the patellar ligament and insertion of the quadriceps femoris tendon. The inferior articular surface of the tibia is located on the distal end of the tibia where it articulates with the talus. It is concave anteroposteriorly and broad anteriorly. Also located at the distal end of the tibia is the medial malleolus of the tibia. The medial malleolus is a pyramidal projection on the medial side of the ankle that articulates with the medial surface of the talus. Next, we will review the fibula. The head of the fibula is the proximal end of the fibula. It is an irregular bulbous projection that articulates with the lateral condyle of the tibia. The fibular shaft lies distal to the neck and has three surfaces: lateral, medial, and posterior. The interosseous borders of the fibula and tibia are sharp borders which run longitudinally along the junction of the lateral surface of the tibia and medial surface of the fibula. The interosseous membrane attaches to these borders and connects the two bones to form a fibrous joint. Finally, the patella is a thick triangular bone that is the largest sesamoid bone in the human body. It is in the tendon of the quadriceps femoris muscle. It covers and protects the knee by withstanding the grinding forces of the quadriceps femoris tendon against the patellar surface of the femur. Next, we will move on to the articular structures of the knee complex. The tibiofemoral joint is a synovial hinge joint formed between the convex femoral condyles and the slightly concave tibial plateau. The medial meniscus of the knee, or the internal semilunar cartilage, is a flat, circular, fibrocartilaginous band which covers the articular surface of the tibia. It is one of two menisci in the knee joint, the other being the lateral meniscus. The medial meniscus of the knee joint helps to stabilize and support the medial aspect of the knee. This area of the knee joint can be injured or torn by twisting the knee or applying direct force to it, as seen in contact sports. The medial meniscus is more commonly injured than the lateral meniscus. The lateral meniscus of the knee joint, otherwise known as the external semilunar cartilage, is a flat, circular fibrocartilaginous band which covers the articular surface of the tibia. The lateral meniscus of the knee joint helps to stabilize and support the lateral aspect of the knee. This area of the knee can be injured or torn by twisting the knee or applying direct force to it, as seen in contact sports, much in the same way as the medial meniscus can be injured. The lateral meniscus is less commonly injured, though, than the medial meniscus. The proximal tibiofibular articulation, also called the superior tibiofibular joint, is an arthrodial joint between the lateral condyle of the tibia and the head of the fibula. The contiguous surfaces of the bones present flat oval facets covered with cartilage and are connected together by an articular capsule and by anterior and posterior ligaments. The patellofemoral joint is formed by the articulation between the trochlea, the distal articulating surface of the femur, and the patella, which are the main articulating surfaces of the patellofemoral joint. The patella lies within the quadriceps tendon, thereby increasing the mechanical advantage of the quadriceps mechanism. Not only does the patella increase the force of knee extension by 50%, but it also provides stability to the patellar tendon and minimizes the forces placed on the femoral condyles. Static stability at the knee is provided by a network of extracapsular and intracapsular ligaments, some of which are implicated in many injuries commonly diagnosed and managed by the sports medicine practitioner. The intracapsular ligaments include the anterior cruciate ligament, or ACL, which extends from the anterior intercondylar area of the tibia to the posterior part of the medial surface of the lateral condyle of the femur. The ACL prevents forward movement of the tibia in relation to the femur and controls rotational movement of the knee, which is essential for pivoting movements. The posterior cruciate ligament, or PCL, connects the posterior intercondylar area of the tibia to the anterior part of the lateral surface of the medial condyle of the femur. It prevents the femur from sliding forwards off the tibial plateau and is the primary restraint to posterior drawer of the tibia on the femur. It is also a secondary restraint to external rotation. The extracapsular ligaments include the fibular collateral ligament, or FCL. This is a broad band located along the lateral aspect of the knee region. It connects the lateral epicondyle of the femur to the head of the fibula. Unlike the tibial collateral ligament, the fibular collateral ligament is not fused to the lateral meniscus or capsule. Its main function is to keep the knee stable as it moves through its full range of motion. It is more flexible than the medial collateral ligament, making it less susceptible to injury, but is stressed during varus motion of the knee. On the medial side, the tibial collateral ligament, otherwise known as the medial collateral ligament or MCL, is a broad band on the inner knee and attaches to the medial epicondyle of the femur and the medial margin and surface of the tibia. The medial meniscus is attached to its deep surface and it is continuous with the fibrous capsule. The main function of the tibial collateral ligament is to keep the knee stable as it moves through its full range of motion. It is less flexible than the lateral ligament and therefore is more susceptible to injury. It is stressed during valgus motion of the knee. Next, we will review the muscular structures of the knee, starting with the muscles of the thigh. The muscles of the anterior compartment of the thigh mainly flex the thigh at the hip joint and extend the leg at the knee joint. The muscles of the anterior compartment of the thigh consist of 5 muscles. The iliopsoas, which is actually composed of 2 muscles, iliacus and psoas major. The tendons of these 2 muscles unite to form one common iliopsoas tendon, which inserts into the lesser trochanter of the femur. The iliopsoas flexes the thigh at the hip joint. Psoas minor flexes and laterally flexes the lumbar vertebral column. It also assists in the upward rotation of the pelvis. Sartorius is a biarticular muscle crossing both the hip and knee and flexes, abducts, and externally rotates the thigh. It also flexes and internally rotates the leg at the knee joint. Next, the quadriceps femoris. The quadriceps femoris is a combined term for 4 muscles, including the rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius. The tendons of these 4 muscles unite to form one common quadriceps tendon. The fibers of the quadriceps tendon travel superficial to the patella, where they become continuous with the patellar ligament. The patellar ligament inserts into the tibial tuberosity. The quadriceps femoris muscle extends the knee at the knee joint. And the final muscle in the anterior compartment group is the articularis genus, which retracts the suprapatellar bursa and elevates the articular capsule of the knee joint during extension. Next, the muscles of the medial compartment, which mainly adduct the thigh at the hip joint. These include pectineus, adductor longus, adductor brevis, adductor magnus, and gracilis. The pectineus adducts, internally rotates, and weakly flexes the thigh at the hip joint. It is also involved with stabilization of the pelvis. The adductor longus adducts and flexes the hip joint. while the adductor brevis adducts and weakly flexes the hip joint. It works in conjunction with the adductor longus. The adductor magnus has two parts, an adductor part and a hamstrings part. The adductor part, as the name suggests, adducts the thigh, but also weakly flexes the thigh. The hamstring part extends and externally rotates the thigh. The gracilis adducts and flexes the thigh and internally rotates the knee joint. And then finally, the muscles of the posterior compartment of the thigh, otherwise known as the hamstrings. The hamstrings mainly extend the thigh at the hip joint and flex the leg at the knee joint. The first muscle in this group is the biceps femoris, which lies laterally within the posterior compartment and attaches the ischium and femur to the fibula. It extends the thigh at the hip joint and flexes the leg at the knee joint. For descriptive purposes, the biceps femoris muscle is divided into a long and a short head. The semitendinosus extends the thigh at the hip joint and flexes and internally rotates the knee joint. And then, the final muscle in the hamstring group, the semimembranosus, which, like the semitendinosus, extends the thigh at the hip joint and flexes and internally rotates the knee joint. The popliteal fossa is a diamond-shaped depression on the posterior aspect of the knee. It houses the popliteal artery, its deepest structure, the popliteal vein, and the tibial and common fibular nerves. The small saphenous vein can be found in the superficial popliteal fascia descending through the roof. It also ascends to penetrate the deep fascia. The posterior cutaneous nerve of the thigh also descends through the superficial fascia that forms the roof of the popliteal fossa. The relevance of the popliteal fossa for our understanding of functional anatomy is based on the premise that, if we understand the boundaries and its contents, we can better identify many of the structures within. So let's review the boundaries that form the popliteal fossa, beginning with the superomedial boundary, which is formed by the semimembranosus muscle. Recall that two of the hamstring muscles, the semimembranosus and the semitendinosus, both pass along the medial aspect of the knee. The semimembranosus is a large muscle inferiorly and forms the medial boundary superiorly of the popliteal fossa. The superolateral boundary is formed by the biceps femoris muscle. Recall that the biceps femoris has both a long head and a short head, both of which pass across the knee joint along the lateral aspect of the knee. So in summary, the hamstring muscles, including the semitendinosus, semimembranosus, and the biceps femoris long head, form the superomedial and superolateral boundaries of the popliteal fossa, respectively. Regarding its inferior aspect, one muscle forms both the medial and lateral boundaries, the gastrocnemius muscle. Specifically, the medial head of the gastrocnemius forms the inferomedial border, and the gastrocnemius lateral head forms the inferolateral boundary. The floor of the popliteal fossa is comprised of the surface of the femur along its posterior distal end. And the roof of the popliteal fossa is the overlying skin and popliteal fascia. The popliteus muscle itself plays a prominent role in medial rotation of the tibia when the foot is not fixed, or in the open kinetic chain, or lateral rotation of the femur when the foot is fixed to the ground, in the closed kinetic chain. The popliteus also controls the position of the lateral meniscus of the knee, pulling it posteriorly during knee flexion to stop it from getting trapped or pinched. In this lecture, we reviewed the osseous, articular, and muscular structures of the knee. This lecture was prepared for students enrolled in the physiotherapy program in the UCD School of Public Health, Physiotherapy and Sports Science. Images were provided from the Complete Anatomy software application prepared by 3D4 Medical.